Now, in the fifth and final section of our lecture, Brain Abscess, we will talk about neurocysticercosis and toxoplasmosis. And as I mentioned, neurocysticercosis is one of the very common cause of brain abscesses. So in this, we will talk about these two conditions and how they present in the patient, what's the treatment of these two conditions and the presentation, and what are the diagnostic steps that we can perform for the diagnosis of neurocysticercosis and toxoplasmosis. So infectious focal central nervous system lesions, non-bacterial causes. The non-bacterial causes, we have neurocysticercosis, common parasitic disease, by ingestion of contaminated food, eggs of the parasite Taenia solium usually cause neurocysticercosis. It's a common parasitic disease, causes the brain abscess, and in this the egg of the parasite solium can cause the disease, which is ingested by the contaminated food. Next, the non-bacterial cause of focal central nervous system lesion is the toxoplasmosis, which is parasitic disease due to Toxoplasmosis gondii by ingestion of undercooked meat and from handling of cat feces. So two non-bacterial causes of focal neurological or focal central nervous system lesion. We have neurocysticercosis, and then we have toxoplasmosis, both by ingestion of one by ingestion of contaminated food, toxoplasmosis by ingestion of undercooked meat which is not properly cooked, or patients who or person who handle the cat feces, they can develop toxoplasmosis. Clinical presentation of these two conditions for neurocysticercosis, there are cysticerci in brain parenchyma. Here you can see the cysticerci which are present in the parenchyma of the brain. Seizures or focal neurologic deficit is present in neurocysticercosis. Increased intracranial pressure by interference with the flow of cerebrospinal fluid that cause obstruction to the flow, cause increase in the intracranial pressure. And then there is also inflammatory response to the cysticercosis, and then it can have its reaction, inflammatory reaction. So these are some clinical presentations of neurocysticercosis. Cysticerci first lodge in the brain, frequently cause little in way of inflammatory response. Cyst degeneration, then inflammatory response occur, and this inflammatory response present as seizure. Eventually, cyst dies off, associated with resolution of inflammatory response, then abatement of seizure. So cysticercosis, as the name shows, cysts are formed, cysts are present, and inflammatory response develop as a result of the rupture of these cysts. When the cyst rupture, there is leakage of the fluid from the cyst that initiate an inflammatory response. As a result of that, there is convulsion or seizures develop. Once the cyst dies off, the seizures also are absent. Now, primary toxoplasma infection or toxoplasmosis often is asymptomatic, no symptoms are present. Parasites may spread to central nervous system. Reactivation of central nervous system occur if the immunity is low or if the person is immunocompromised, like HIV infection. So they are often asymptomatic, may spread to central nervous system, and in immunocompromised host there is reactivation of infection occurs. Features of toxoplasmosis: we have fever, headache, seizures, focal neurological deficits are present. Now the diagnosis, how we can diagnose. Lesions of neurocysticercosis are visualized by CT scan, and MRI can be done, and in which we can see the presence of the cysticerci. Lesions with variable parasites appear as cystic lesions. Cystic lesions are present. Scolex visualized on MRI. Lesions as contrast enhancing lesions surrounded by edema. So these are the features present on the visualization of cysticercosis on the MRI and CT scan. We see the presence of cyst, and then scolex is visualized on MRI. Early sign of cyst death: if the cyst dies off, there is hypointensity of vesicular fluid on T2 weighted images when compared with cerebrospinal fluid. So there is hypointensity of vesicular fluid as compared to cerebrospinal fluid. Parenchymal brain calcifications are present, which indicate that parasite is not longer viable. So when calcification is present, here you can see this is the calcification that is the that determines that the cyst is dead. Death of the cyst occur, or it dies off and there is no viable parasite present. MRI finding of toxoplasmosis. Here you can see multiple lesions in deep white matter, thalamus, basal ganglia, at gray-white junction in cerebral hemisphere. Contrast administration. Majority of lesions enhance in ringed nodular homogeneous pattern. You can see ringed pattern, nodular, surrounded by edema. Characteristic neuroimaging abnormalities of Toxoplasma gondii infection. Serum IgG antibody to Toxoplasma gondii when positive patient to be treated. In those with neurocysticercosis, anticonvulsant therapy should be given. Albendazole and praziquantel parasitic antiparasitic drugs can be used. And in those with cysticerci, anti-cysticidal therapy, cysticidal drugs, prednisone or dexamethasone is used. Anti-epileptic therapy is stopped when follow-up CT scan shows resolution of the condition. Long-term anti-epileptic therapy: when seizures occur after resolution of edema, we should continue anti-epileptic therapy for a long time. Resorption or calcification of degenerating cyst. CNS toxoplasmosis, we should use combination of sulfadiazine 1.5 to 2 gram orally 4 times a day QID, pyrimethamine 100 milligram orally or load, then 75 to 100 milligram orally QD. Folinic acid 10 to 15 milligram orally QD. Also, folinic acid prevents the megaloblastic anemia. Continuation of therapy is until no evidence of active disease is present. On neuroimaging studies on CT, MRI, typically takes at least 6 weeks. Dose of sulfadiazine and pyrimethamine reduced after that. Alternative therapy for toxoplasmosis, clindamycin plus pyrimethamine for patients who cannot tolerate sulfadiazine. More effective combination is pyrimethamine and sulfadiazine. So that concludes our topic of brain abscess. Thank you for watching sqadia.com.